Welcome, I'm Michelle Cowles, Director of Business Development with Rogers Behavioral Health, and I will be your moderator for today. With me are two of our clinical directors from locations where Rogers offers trauma recovery services, Dr. Josh Nadeau from our Tampa clinic and Dr. Loren Post from our new Atlanta clinic, which opened on May 11th with telehealth services. Before we get started, I want to give a quick overview of the format. The webinar is scheduled for 90 minutes. In order to receive CE credits, you must be logged into the webinar for the entire program. We are also recording the webinar and will publish it on our website along with the slides for you to rewatch at your convenience. However, please note that CE credits will not be awarded for just watching the recording. Drs. Nadeau and Post will give a 75-minute presentation. Following their presentation, I will facilitate the Q&A session. If you would like to ask our presenters a question during the presentation, please use the Q&A button, not the chat button, to send me a message. At the bottom of your screen, you simply click on the Q&A button on the Zoom taskbar. I will review the questions submitted, then the presenters will address them during the Q&A portion of our webinar. Now, I'll turn it over to our presenters.
Good afternoon, everyone. My name is Loren Post, and I am excited to be with you this afternoon. Just wanted to go over that both I and Dr. Nadeau do not have anything to disclose. And to revisit the learning objectives for today. So upon completion of the instructional program, you should be able to address each of those. So identifying those advantages of telehealth, describing ways to help patients with various comorbid disorders and when implementing PE, and then being able to explain our inter and one intrastate stressor that drives changes in treatment of PTSD. So what we're going to be covering in this webinar, we'll be talking about evidence-based PTSD treatment via telehealth, PTSD and co-occurring disorders, particularly within the context of COVID-19, and then virtual PE for PTSD context and clinical considerations. So let's get started. I'm going to start off by talking more about this evidence-based PTSD treatment via telehealth, specifically going over some of what we know to be true for telehealth when providing PTSD treatment, such as more information on feasibility and effectiveness, dropout, compliance, patient preferences, and then spend a little time talking about similarities and differences in providing prolonged exposure in person versus telehealth. So to start, pointing out that when comparing telehealth delivered PE relative to in-person PE for the treatment of PTSD, the two are essentially equivalent in terms of reducing PTSD scores at post-treatment and follow-up. I want to note that the majority of the studies comparing these two different methods of providing treatment have been conducted within a veteran population. And that's mainly because the VA researchers have been studying telehealth for quite some time now. And that's important because we, at this point, can have confidence in the use of telehealth for the treatment of PTSD. So really the idea being that even if we are providing telehealth rather than our standard in-person treatment, we can still expect meaningful clinical gains following that PE treatment. So talking a little bit about those factors that I just mentioned, telehealth has been shown to be equivalent to in-person CBT treatment on fidelity in delivering treatment. So we can expect that the same important components of the treatments can be delivered and delivered as it has been constructed within that particular treatment in the same way that it would in person. Also, telehealth has been shown to be superior to in-person treatment on lower dropout rates. I'm sure many of you can think of some of the reasons why that might be the case with the use of telehealth, and we will talk about that a little bit more when we start to visit the ways that telehealth can help us overcome treatment barriers. A note on working alliance. So a meta-analysis did show that telehealth has been shown to be inferior to in-person treatment delivery. However, I want to point out that even though it was in fact inferior, that does not mean that working alliance was low. The studies that were examining that particular construct still noted that the working alliance could be categorized as strong. So it's still present, just not at that same level as in person. Also, very importantly, despite that inferior, weaker alliance, the telehealth still produced as much improvement in those symptoms as it did in person. So we can have confidence that we will be able to form that connection, have stated and joined goals in providing these PTSD treatments via telehealth. I mentioned a moment ago about how a lot of the research has been with the veteran population. One study in being able to get an idea of patient preference found that about half of veterans actually prefer to receive PTSD treatment via telehealth. And that, along with what I had just mentioned with the low dropout rates, is likely related to some of these issues here. So a real strength of telehealth is that it can help us overcome treatment barriers that our patients face. One important one is stigma, as well as trauma-related concerns. So an example would be that I'm sure many of you have witnessed how we have patients who come in thinking that PTSD means that perhaps they're weak or that they have gone crazy based off of these symptoms that they're now experiencing. And it can be very challenging to get oneself into a clinic. And by being able to receive treatment from the privacy of their own home, that can usually at least kind of move a person closer to starting treatment or completing the entire treatment via telehealth. Trauma-related concerns also, if avoidance is particularly strong in the beginning, and a patient who has trauma-related reminders to things such as doctor's offices, hospitals, has really difficulty being in crowded places, telehealth would be able to aid with some of those difficulties as well. And then, of course, logistic-based. So some real advantages of telehealth: the travel time to and from appointments can be overcome, parking issues in some of our bigger cities, crowded cities, lost work time to difficulties in scheduling and location. And then in smaller communities, rural communities with less access to the specialized PTSD interventions, a real advantage of being able to hop on and receive session for somebody who's just very well versed in these particular interventions that maybe just have not been disseminated within certain communities. So moving to looking at those similarities and differences then between telehealth and in-person, I'm focusing specifically on prolonged exposure therapy. But keeping in mind that a lot of the data for telehealth related to CPT and other forms of CBT for the treatment of PTSD shows similar presentations and being able to administer them via telehealth and maintain fidelity. So really, for these similarities, the big point is that they're not much different from in-person treatment when providing this PE treatment via telehealth. You won't have to likely make very many modifications to the protocol. One thing to keep in mind just in general when doing telehealth is that rather than modifying it, there can be ways to enhance it, such as the use of certain mobile apps. There are apps out there like PTSD Coach, PE Coach, that just allow our patients a way to stay connected, be able to access from their own phone, from their own app, homework, other tracking that they may need for the treatment that they're doing via telehealth. There are a few things to note about modifications. So within the therapy setting, for PTSD treatment, and really, I think that probably a lot of you have noticed if you have started telehealth for a whole range of presentations, some of the things that can be helpful is informing patients prior to the first appointment to really treat these telehealth sessions like they would if they were coming in to see you in person. So things like wearing appropriate clothing, getting out of bed and finding a private, quiet location to meet. Also doing their best to minimize disruptions. If they can find a way to not have people in the background, doing their best to keep keep the pets, the cats, the dogs out of the room. And of course, we're all in this very abnormal situation where we're trying to adjust to this ourselves. And if we take some extra time maybe to just brainstorm with our patients too of how we can make this best work. So headphones can potentially be an option so that the patients are able to hear us clearly. If it just seems impossible to find a quiet private location in the home, we can think outside the box, ask a patient to maybe go to their car, do a session in the car. Other things of just working with people and pets, whatever it may be, trying to designate a time period too, where asking maybe family members if they can, from this hour to that hour, perhaps take a walk or make sure that they stay in a separate room so that our patients can receive the privacy and the kind of quiet environment that they need. For session materials, really, it can be quite helpful to, before getting started, establish how you're going to exchange those written materials. Some of those written materials for this particular treatment, of course, being homework forms. We will have self-report measures where we want patients monitoring their symptoms and letting us know where they're at in levels of severity. So being able to figure out is it going to be a matter of, as I wrote on that second point, where they can print it out, scan it, and email it to us, if they can take a screenshot of it, making sure that we just understand how we're going to be exchanging those things. It's also really useful to have all handouts provided to our patients in advance. That way they can easily pull it up, we can pull it up, and then look at those materials together. This is just also very useful because it's going to allow for this planning beforehand so that sessions aren't taken up by the time of trying to figure out of how we're going to get these things to each other. And a note on modifications for imaginal exposure, and Dr. Nadeau is going to be talking more about modifications for imaginal exposure and in vivo exposure in a little bit. But in terms of kind of the differences in more of the setting, one thing that we'll want to pay attention to is that patients record the session where they're sitting. So placing whatever device they're using to record in a place where they're able to pick up their own voice as well as the voice of the provider. We can ask patients to use their phone's voice memo. An important note is that if they are using that for the actual session, I'm pretty sure no matter kind of what kind of phone you have, it's not going to work. So we can ask if they have any type of recording devices in their home or purchasing a digital recorder. They're pretty kind of basic recorders that are quite cheap, so that being a possibility if needed. Also, asking our patients to position their camera so that we can really see as much of them as possible. For those who have conducted imaginal exposure, you probably recognize how important it is to be able to see kind of what our patients are doing with the rest of their body as they're revisiting the memory. So we would want to look for things like levels of engagement, safety behaviors. So even being able to see a patient's hands during imaginal exposure could be useful. You know, if a patient's wringing their hands as they're going through as a way to manage that anxiety that we want them to experience, we'd want to be able to jump in and make the suggestion that, you know, they keep their hands at their sides. And then, of course, technological difficulties, they're going to happen. So some things to consider and see how they work for you and your patient. The standard protocol is asking SUDS every 5 minutes when a patient is going through imaginal exposure. So asking what that anxiety level is. One way that we can minimize disruption, especially since it's not as fluid when we're doing it via telehealth, would be to just get pre, post, and peak. So right before they start the imaginal, asking what's your number, and then when they finish, what's your number now, as well as how high did that number get when you were going through the exposure. The less interruption, the better. And finally, for these momentary glitches, so whether internet is cutting in and out a little bit, obviously using judgment, but one possible suggestion would be if there are those quick moments where, these brief moments where you're not able to hear your patient, consider allowing the patient to continue without saying, can you repeat that? I can't hear you. And that again is just so that we can hopefully get the same level of effectiveness that we would get in person, meaning that the patient is fully engaged in that memory and they're able to go through in a repeated way without interruption. So moving on to talking more about the presentation of PTSD with co-occurring disorders, I'd like to talk about increased severity of PTSD, transdiagnostic symptoms, likely in response to COVID-19 concerns and other related stressors, and then normalizing those concerns and reactions while setting expectations for symptom improvement in response to PE, and then managing co-occurring disorders and life stressors throughout PE treatment. So, more specifically, quick kind of basic foundational information. What we know about PTSD is that it has one of the highest psychiatric comorbidity rates of any disorder but depression. Some of the most common comorbid diagnoses: major depression, whole range of anxiety disorders, substance use disorders, borderline personality disorder, and psychotic disorders. Just to touch base, I know I've already been talking about PE and imaginal exposure, but the 4 components of PE being that imaginal exposure, which is revisiting the trauma memory and processing the experience; in vivo exposure, so exposure to trauma reminders in life. We provide psychoeducation about common reactions to trauma and teach a breathing retraining skill to help patients learn to breathe in a calming way. So I say all that and kind of provide that review because what I want to get across now is that with all of these expected factors or components of the treatment that we want to accomplish, even outside of our current situation, we know that when patients present in these complex manners, PE can still be effective. And that's important to keep in mind even as we think about adding yet another complexity to patient presentation with potential concerns about COVID-19. So with that, we do know that PE is effective for patients with these comorbid disorders, as well as patients that have associated symptoms that we often very much see with PTSD, like guilt, anger or aggression, dissociation, suicidal ideation, gestures, and poor health. We can expect within the ones I just named, as well as some complexities like a target trauma of childhood sexual abuse or a history of childhood abuse, we can expect patients to do just as well in PE as those who do not have those complexities. Additionally, in being able to tolerate the imaginal exposure just as well as those who don't present in that same way with those comorbidities and other complexities. And importantly, so I mentioned kind of we could see these improvements in these other areas like depression, functioning, dissociation. Importantly, in some of the other presentations, even if we're not seeing decreases, we can feel confident, of course, always assessing and it varying with patients, but can feel confident that at least some of those symptoms won't increase during PE. So it may require kind of an additional treatment afterwards, but we can expect that that remains steady as we continue to focus in on providing PTSD specific treatment. So with all of that, in knowing that a lot is going on for our patients, I want to bring in then this piece of COVID-19 concerns and some of the ways that it can be handled. So to start, pointing out that from our trauma experts and those who have been studying this for a very long time, developing our treatments, there is this prediction that what is likely going to happen is that those who are kind of experiencing this stress, that they will be able to cope with it in real time. So finding ways to manage it to where kind of this one day at a time coping and being able to get through and tolerate the uncertainty of what's going to come next. And even those who are highly distressed in this real time, there is the prediction that natural recovery will occur, so that as time goes on and people get back to the new normal, that adjustment will occur in a natural manner. So those stressors, the anxiety, the distress related to it will begin to improve and people getting back to their lives in a new normal. So I think for us, it's important to remember when our patients come in with these concerns that we certainly don't want to over-pathologize it. This is a normal response. I know that many of us are experiencing some of these stressors and the distress as well. So it is a normal response to a very abnormal situation. What we can do is when our patients come in with these concerns and we, in being able to have discussion with them about these concerns more specifically and how it's affecting them, if we determine that the appropriate way to move forward is to stick with PTSD treatment, a little bit of time in the beginning can be used to discuss how self-management of these concerns related to COVID-19 specifically could be very helpful. So being able to ask ways that perhaps your patients have coped in the past. Of course, we'll have to make modifications to some of them. So even the ones I have up there with exercise and social support, and see if you can help them plan those particular modifications. And some of the suggestions too with this particular situation, if we think of Maslow's hierarchy of kind of basic needs, we certainly want people to feel like they're safe. So managing the best that they can to where, depending on your state, if it is stay-at-home orders, that's being followed, using social distancing, using PPE, and making sure that that's in place, and also kind of just having basic needs met. And a big part of that too is that connection. So being able to still have a sense of community, social support. Of course, that will look different in that for many of us and many of our patients, we're not going to be able and meet up with friends. And so working with your patients to figure out what are some ways that you can get around that whether it be over the phone, in a virtual world. Also, gaining access to structured self-care, helping a patient structure what their self-care is going to look like throughout the day, throughout the week, providing information on enhanced mindfulness, exercise, sleep, or relaxation strategies, really just helping put these things in place with, after an assessment, the recognition that most likely our patients will be able to manage these concerns even outside of treatment, which is focusing on PTSD specifically. One resource that I wanted to put up here is COVID Coach. This is an app that was created by the Department of Veterans Affairs, and it is used to support self-care and overall mental health during this pandemic. Even though it was developed by the VA and it even says veterans on the app, it is meant for everyone. It's not just veterans and service members, it is for civilians as well. So that could be a good resource to introduce to patients too. So in talking about PE during COVID, one additional point to make based off of that past slide, certainly it may go beyond stressors of our current situation, keeping in mind that some of our patients may have experienced additional trauma, the loss of a loved one suddenly, if it is a frontline healthcare worker, the witnessing of multiple deaths. So keeping in mind that we will want to get more information and see how a person's doing if there has been exposure to an additional traumatic event. But in staying kind of the course and continuing to do PE for a patient that you've kind of already had in treatment and are moving over to telehealth or even doing in person, we can expect that there's going to be worsened PTSD symptoms. And I think a lot of those worsened symptoms are going to be on that very common shared anxiety, depressive disorder spectrum. So things like sleep disturbance, negative emotional state, concentration. And it's our job in being able to get information on why we're seeing this worsening, and with the understanding that it would be commonplace in some ways that these things, these difficulties would increase. And keeping in mind then, as we see that in relation to our assessment and seeing that this is perhaps adding to some of the distress, determining that it likely won't need an additional diagnosis or a change in your treatment plan. It's this kind of figuring out with your patient, what are their presenting concerns, what has changed since COVID-19, and if it seems like PTSD is still primary, it might be useful with the self-management of some of the COVID-19 related concerns, staying with this PE treatment, your original treatment plan. I put this note on here because it is important that there have been some findings that telehealth performed more poorly than in-person PE with respects to depression symptom scores. So I want to point that out because especially within our telehealth world, we may not have some of the advantages that are present with in-person, such as with in-person, there's this already kind of built-in activation component. So patients have to get up, they have to get in their car, drive over to the clinic, and that's missing from telehealth. Also, usually when you're in a in-person session, able to pick up on these things, I think, more readily, and then kind of even add these impromptu exercises, adding a behavioral activation to their in vivo exposure hierarchy. And so because we may not have those same advantages via telehealth, just keeping this in mind, especially if you're seeing an increase in those depressive symptoms, keeping in mind that you might want to spend or give extra attention to those difficulties. Oops. There we go. So With that, I've mentioned this about if it's determined to be PTSD as the primary diagnosis, we can maintain our focus on that PTSD, on the PE treatment. The other piece is really, I think, projecting confidence. So as these life stressors continue in the background, letting patients know that, again, this is a normal response to an abnormal situation, and they're doing great in working towards really reaching their goals in relation to being able to kind of take back what PTSD has taken from them. The reason why I wanted to go over some of the complexities and the comorbidities that we typically see anyway with PTSD when we're in person, when there isn't a pandemic going on, is that we know that there often are these complex presentations, and a lot of times our patients have multiple life stressors, there are crises going on, oftentimes in response to their symptoms. That's why I think it happens so often in patients presenting that way. So whether it be because of re-experiencing or hypervigilance interfering in their ability to get things done, or how families responding to it. And we know that PE can still be effective and that we can still maintain focus on the treatment with those situations. And I think for us, maybe thinking about it in the same way, even with this pandemic, that yes, this is an extraordinary time, but again, if the patient and provider have decided that this is the best path to take in treating PTSD, we can still do it. We can still make it happen. Of course, us paying attention to now, and if we were in a more normal time, if there's self-destructive impulse control problems, if there's anything that needs to be addressed immediately to where it would take us a little off course of that PTSD trauma, definitely paying attention to that and doing what's needed so that PE can be provided in a safe and effective way. The last thing I want to touch on is kind of the continuing motivation for our patients and doing a really kind of intensive treatment that requires a lot of practice, a lot of work during this very stressful time. So things like letting our patients know that by continuing in this treatment, we are kind of giving the best help possible. We know that this is going to help them get to a place where PTSD symptoms, other symptoms related to PTSD will decrease, and hopefully put them in a place where they're better able to cope and function. Really kind of, if needed, bringing people back to their original goals. What were some of the reasons that you wanted to start this treatment in the first place? What is it that you want to be able to take back from PTSD, start doing in your life again? And that being a motivation to maintain focus, stay the course with this treatment, and really just applaud healthy coping. I think we all deserve an applause in being able to kind of maintain work for our patients, maintain treatment in such a difficult time. And so just pointing that out to our patients that, you know, as they use those self-management skills, they're still completing PE homework. That's a huge accomplishment. So really the aim being, again, with assessment, communication with your patient, that we want to provide support through the crisis, yet if it is appropriate, certainly can be extremely helpful, just as effective as in person, to provide our PTSD treatments via telehealth. And so I'm going to now pass it over to Dr. Nadeau.
Thank you, Dr. Post. I appreciate it. Michelle, were there any kind of burning questions that have come up with Dr. Post part of the presentation that we might want to address first?
Yes, there is a question. I wonder if there is a difference between male and female patients in preference for telehealth versus in person.
Dr. Post, you're muted.
Okay. I would say not that I'm aware of. I can put out information related to more of kind of generational preferences. So for some of our younger populations, and I'm thinking specifically in veteran research, those for more of the more current conflicts and treating PTSD, that there often is a preference for things like VR, so the virtual reality system. And we can potentially say that that might translate over to being able to use this technology, being able to do sessions via telehealth. But I don't know, Dr. Nadeau, if you know more about differences with gender.
It's a really good question. I'll be honest, I haven't seen anything in the literature on as regards specific preference for telehealth over in-person by male and female. And there's a lot of, I could make an educated guess, but there are so many factors in play. It would be difficult to determine. It's a really good question. You can bet that after this is over, I'm going to go look that up.
Oh, thank you. And another question, if a patient or client is uncomfortable with camera precisely due to feeling exposed, trigger trauma, would you opt to not use exposure interventions, or would you move forward with PE intervention even if you cannot see them?
That's a great question. So I think we certainly want to lay eyes on our patient as we're going through the therapy. One approach that we could consider would be starting off in the beginning, working with a patient to, one, discuss the importance, but also perhaps treat it as we would an exposure. So discuss that, it is going to likely be anxiety provoking to start, and we'll sit with it, that they will get used to it, and hopefully get the patient to a place where they are able to leave it on for our sessions.
Okay, and there is one more question that we could answer now before we continue. How much data does COVID Coach collect? For example, is it HIPAA compliant? Does the VA have access to client information?
Interesting. No, so there is not any kind of direct access for the VA. It is a personal app, and that data will remain on people's phones. In terms of HIPAA compliance, not that I am aware of. It generally has some features. So for PE Coach, there's a feature where patients actually aren't able to share recordings from the app. And that's partly so that that remains within their phone, within their possession. So it being protected in that way, and of course, none of that data being shared.
Okay, and I think the rest may be covered or more appropriate after the end of the presentation.
Okay, well, thank you, Michelle. Good questions. Yeah. Happy Thursday, everyone. What I'm going to do is I'm going to try to build off of what Dr. Post has shared to this point in terms of kind of some of the things to expect and what the literature has told us. I'll talk a little bit about what it's like to conduct virtual imaginal exposures through the magic of telehealth, for those of you who haven't done that. We'll also talk about some considerations that have to do with social distancing, or what might be called safety distancing, with some special attention to some safety behaviors or avoidant behaviors. And then we'll kind of bring this home by talking about some of the advantages and challenges that present themselves in terms of not only doing telehealth treatment now, but for those of us who started out doing in-person treatment and have made the shift to telehealth, what are some of the things that might sneak up on us and make it difficult or challenging to shift back to in-person? Before I move on to the next slide, there's a couple of things that I do want to talk about. And so first off, what I'll point out, and you may have picked up on this by listening to Dr. Post, is that PTSD is interesting in that it has one of the most robust literature bases in terms of what's been done for whether supporting or raising challenges or giving us considerations that have to do with virtual or remote treatment practices. And so when we kind of consider the advantages and challenges of telehealth, it behooves us to take a closer look at PTSD more than almost any other disorder. PTSD also has this kind of traditionally split approach to treatment, whereas, physically in session, when you're, if you're meeting in person with folks, you tend to review the in vivo exposures that have been done. You may conduct those imaginal exposures that are there, and then processing through both of those types of exposures. And then contrast that against the homework portion of treatment, where typically your patient is not in session with you, but they're doing this from home or wherever they may be. And here we see them conducting in vivo exposures, but also kind of reviewing or going back through these previously recorded imaginal exposures. And so when we kind of think about this natural split in the treatment, it's really interesting to look at the telehealth approach to how we might treat PTSD and really trauma of any sort. What I will point out is, as much as we are kind of talking about these enormous changes and the impact that they can have not only on our patients, but ourselves and our colleagues, it's important to keep in mind that with all of this change, there have really only been two kind of major changes in terms of the COVID-19 and post-COVID-19 environment. The first is this idea, again, of social distancing or safe distancing, and specifically kind of looking at how this changes the nature of our in vivo exposures, as well as kind of how this situates the therapists and the clients when we're conducting imaginal exposures. I believe we'll talk a little bit more about this later, but there's a world of difference between kind of sitting with your client or your patient and having them open a window, for lack of a better term, into a pretty significant traumatic event while being in what they recognize as a safe space, as opposed to them being in their home or somewhere else that may or may not be considered a safe space for them. And the window that's being opened is actually your ability as a therapist or the psychologist or the psychiatrist working with your client. And so there's kind of this loss of a sense of control that I believe we're used to. So there's one large change. And then the kind of the second change that we look at is in terms of the nature of the pandemic and the nature of looking at what we're doing with distancing is kind of the juxtaposition here in terms of increasing the distance. And what we find is there's actually this narrowing of a margin between what we might consider pathological behaviors or these safety behaviors that we see, as opposed to pretty legitimate safety concerns that are at a much higher level than we've been accustomed to seeing in the past. So when we kind of use those two changes and kind of this thinking about PTSD treatment in general and traditionally, it gives us a really good lens through which to kind of approach the rest of the presentation here. So Dr. Post, if you wouldn't mind going to the next slide, I would appreciate it. Thank you. So in terms of, again, talking about this idea of change, it's obviously a theme that will show up throughout the presentation. It's pretty instructive to kind of think about the differences in target or the differences in focus between the different types of exposures. So when we talk about in vivo exposures, what we're really looking at, the kind of overall goal here of these exposures is to decrease functional impairment, or if we positively state it, is to increase our level of adaptive functioning by reducing these safety behaviors. Specifically, what we're talking about is decreasing avoidance of certain aspects of the environment that our patients may find triggering. So why do I bring this up? It seems pretty obvious. There's a need here in the environment we find ourselves in to select these in vivo exposures that are going to increasingly approach not only the triggers that we're accustomed to dealing with our patients, but also to kind of increasingly approach this dotted line or this dashed line, if you will, between those pathological and legitimate safety concerns. So in other words, as we see the people around us in the environment that we expose ourselves to, for lack of a better term, we see many of them engaging in behaviors that if we as a patient engaged in might be labeled as pathological or as a safety behavior. And this has been encapsulated quite nicely by a colleague of ours, Dr. Marty Franklin, and I'm sorry he's not here to hear this, but I will pay him tribute by saying that it's important that we follow CDC, not PTSD, when we're talking about kind of guidelines for these safety behaviors and kind of what do we need to do to remain safe while also kind of not shutting down or avoiding things entirely. When we think about afterwards, after those in vivo exposures, and in terms of kind of how do we process those in vivo exposures, normally what we find ourselves talking about in the processing is the utility or the lack thereof of these safety behaviors or these avoidant behaviors as being helpful or coping with the trauma in some fashion. And usually, spoiler alert, those safety behaviors don't help us cope with the trauma, but they represent a way to avoid those triggers so as not to put ourselves in that uncomfortable position. So again, when we think about the environment we find ourselves in with these changes related to COVID, this discussion or this processing of the in vivo exposures really has to also encompass the emotional experience of your patients because of those narrowing margins we talked about. So in other words, what's it like to be in an environment where I ask you to do something that would normally be difficult for you? How much more difficult is that? How much more kind of arousal or anxiety are we finding because you are seeing other people around you while doing this exposure, engaging in what look for all the world to be safety behaviors? What's that like for you? By the same token, when we kind of flip this over and look at the imaginal exposures and doing them virtually, as a reminder, when we talk about the imaginal exposures, although they are not in vivo, they are very much usually focused much more on the original traumatic event. And so when we kind of think about this, we're really addressing the specific triggers here as well. And what we want to notice is that depending upon kind of these individual manifestations or individual symptom presentations. So in other words, you may be dealing with patients who, as part of their traumatic event, have had people forcibly place their hand over their face to prevent them from being able to breathe or to keep them from being able to talk. And now we're looking at kind of an environment where we're being told that it's important to wear a mask to be around other people. And it's something that not only kind of physically provides this barrier, but for all the world can be a trigger. So when we kind of think about this idea of restricted breathing or of the notion or the perception that their activities are being curtailed or they're being told where they can and can't go, that can be very triggering for some of our individual patients. So when we think about this, the impact of this environment upon the imaginal exposures, depending on your patient, could vary from not really any impact at all to quite significant. So again, these kind of differences that we talk about, it's really important that we consider not only that, but some of the other differences, as we've talked about in terms of our role as the therapist, are more to the idea of, so my background is school psychology, and something that we talk about a lot with educators is this idea of what's called proximity control. And usually when we talk about that, what we mean is maybe I almost said a patient, a student in the classroom is engaging in some disruptive behaviors. And sometimes simply by moving that student's assigned seat closer to the instructor or to the teacher or to another adult will cause the frequency of those behaviors to go down because they're closer to the adult, if you will. We don't usually think about it that way, but there is an element of proximity control in terms of kind of how we deal with our patients. And specifically when we talk about these differences in the environment, again, instead of opening that window onto the traumatic event while sitting safely with the patient, you are now distant, for lack of a better term, but quite literally opening a window onto the patient being in what may or may not be a safe environment while they revisit this traumatic experience. And so there kind of has to be this discussion, particularly when we talk about processing the imaginal exposures related to the self-evaluations. So, I mean, these are the things we normally would process, these feelings of helplessness or worthlessness or shame, but also kind of global evaluations in terms of the potential threats, the sources of help around us that surround this traumatic event. And so there's a challenge here that's pretty unique to this form of treatment, where we want to include in that processing any of those kind of manifestational differences we talk about in terms of, are there things unique to this traumatic event that play or have a very negative synergistic impact when we talk about the changes in the environment around us. So just some things to kind of think about as we step through this. So kind of overall, what we want to talk about are those saying that last bullet point on the previous slide. When we kind of talk about there's really no change in the ingredients of active treatment. What's really changing is how we're implementing them and the things that we're looking at. And Dr. Post, that's actually fine. You can go to the next slide if you like. I appreciate that. Thank you. So when we talk about going through these exposures, it's really important that there's kind of three things we consider. And the first are some of the assumptions through which we approach treatment itself. And so kind of a guiding assumption in traditional PTSD treatment research is that, within a session, if you will, whether we're talking about Imaginal or as homework and in vivo exposure, we're sort of looking for this buildup. It may be rapid, it may be not, and then gradual de-escalation of subjective distress following the exposure. And so this is what we typically would refer to as a within session or a within trial habituation. And if you're not familiar with this, habituation is just a very expensive term that means getting used to it. So when we kind of talk about the importance of this, the importance of within session or within trial habituation has actually been what's driven traditionally what we refer to as the prolonged portion of prolonged exposure. What's interesting is when we look at some relatively recent studies. So in 2006, there's a study that compared hour-long sessions versus what might be termed abbreviated or 30-minute sessions, looking at prolonged exposure, incorporating imaginal exposure. There were some pretty interesting findings. Specifically, when they looked at people going through the 60-minute versus the 30-minute sessions, there really wasn't a significant difference in their response to treatment. Specifically, what we're talking about is the amount of symptom severity reduction as well as restoration of functioning. So they were pretty analogous. There was not really an enormous difference between them. Also, not a significant difference in the amount of what's called between session habituation. So in other words, whether or not your anxiety peaked and subsided within that session, the next time that we would have you engage in that exposure, it was easier for you or less arousing or anxiety provoking than the previous iteration of that. And so not a lot of difference between those two in terms of between session habituation. But what we find is in the shorter sessions, as you might imagine, there was less of that within session habituation. So this raises a question for us of if treatment response wasn't different between those two conditions, but the within session habituation was different, is within session habituation really necessary to treatment response? And so then we kind of saw this spate of research come out over the next 5 or 6 years after the study. And it's what I lovingly refer to as the limbo phenomena with session times in mind. In other words, how low can you go in terms of, how long your sessions are. And so then in 2015, there's this great study that comes out where, again, they compare two different conditions, this time 60-minute and 90-minute sessions. Now, the findings from this study suggested that there is some minimum amount of within session habituation that needs to occur in order for treatment to work. In other words, there has to be an element of being able to sit through and withstand that kind of exposure and then process through it in order for treatment to work. However, anything beyond whatever that threshold amount of within session habituation, anything that we added onto that really kind of showed diminished findings in terms of it didn't really seem to make much difference in terms of treatment response. So kind of as with most research, the findings of this, answering one question, raised at least two more. And those two that immediately popped to mind were, well, how much within session habituation is enough to meet this threshold? And two, regarding that threshold effect, is that something constant? Is it something that differs by individual? Is it something that differs by the types of symptoms or the type of initial traumatic event? What's going on here? And so what we find is over the last several years, there's been kind of this seeking out of the holy grail to find out how much is the Goldilocks amount, how much is just right, not too much or too little. So some assumptions that we look at. If we move on to the expectations, the literature basis, the base is pretty consistent with this notion that came out in the mid 80s when we talk about Dr. Foa's study, that when we activate the fear structure, so in other words, when you are afraid or anxious, and we do it in a gradual, controlled manner, and then towards the end of that, as we sit through and present our clients or our patients with what we might call disconfirmatory information, we see this we see two phenomena show up. The first is that between session habituation. So in other words, the more that we expose you to it, the less it seems to bother you or cause anxiety. And second is that regardless of whether you're engaged in an exposure or not, your overall baseline level of threat monitoring, so the amount that you think about this, your overall level of subjective arousal, so that emotional piece, and your overall level of structural or situational avoidance, the behavioral piece, all of those begin to come down regardless of whether you're in the middle of an exposure. When we put those together, that's really what we would refer to as treatment response. So some expectations here that this should work. And then finally, some things to look at in terms of concerns that are specific to telehealth. And here there's kind of two studies that I thought were really interesting. One was by Gross and colleagues in 2013. And they make this great point that when you're talking about telehealth or remote treatment, it's not as though you have written instruments that you can provide with your clients or your patients to get some idea of where they are in terms of symptom severity at any given point in time. So not only kind of this baseline symptoms, but also kind of in-session examples, so different handouts and materials that we might use. So there's this need to increase that amount of communication of that really important information, but how do we do that? And so what we found is, as Dr. Post had mentioned, there are several resources out there, but also what's really important is that we communicate our expectations about that ahead of time. And so what we'll find is there's this need for a reliable method of digitizing this exposure material for our patients or our clients. And then another study, and I believe Dr. Post also had referenced this earlier, it's actually a dissertation by Hernandez Tejada in 2014. And what was really interesting was the student followed up by telephone with participants who had dropped out of prolonged exposure sessions for PTSD. Something we're really bad about doing is following up with patients to find out why they dropped out. And so what they found was looking at differences between in-person and telehealth treatment of PTSD, there wasn't a significant difference in the rate of attrition or the rate of dropout for patients or clients. What we did find is that what would make sense to you is that in that in-person type of treatment, the majority of attrition, or at least the reasons that were given for attrition, had to do with more logistical concerns, arranging transportation, finding a place to park. If you've ever been to a VA hospital, the struggle is real when it comes to finding a place to park. Financial issues in terms of how am I going to pay for this? How am I going to get my insurance to pay for this? Setting aside the time, not only for the sessions, but also to get to and from, arranging for childcare, all these other things, time off of work. By a kind of a different token, when we look at the telehealth attrition, what we found is that the majority of reasons given for dropping out had nothing to do with logistical concerns. The overwhelming majority had to do with the ability to withstand or tolerate this distressing treatment or exposures. The last interesting piece I'll point out about that study is that they found that in both conditions, the patients or clients involved endorsed a pretty strong and consistent liking and respect and confidence in their therapists. So there'd been some question about, well, maybe people doing telehealth won't take it as seriously or will have a different relationship with their therapist. And so it's interesting to find that the information is not consistent when it comes to that. So if you wouldn't mind going to the next slide, I'd appreciate it. Thank you. So when we kind of talk about how to approach this, there's really three things we want to take a look at. The first is in terms of assessment. It's really important that we not only get that subjective level of distress, but also what we might call arousal and velocity. So there's something really interesting that some of our therapists use, which is not just the SUDS, where are you from 0 to 10 or 0 to 100, but also a feeling speedometer. So not only are your feelings changing, but how quickly do things seem to be going? And they have this great picture of like an older analog speedometer that goes through. I like these, one, because they let us know exactly what's going on, but because they're visual aids, I don't have to interrupt my patients in doing telehealth to assess where they are at any given moment. I don't have to interrupt the flow of their exposure because either I can point to this and they can just say a number, or even far better in my eyes is they can have this. And, as they start to find something going on, as they're talking to me, they can point out what's going on, or they can adjust that speedometer accordingly. So I really love the idea of kind of incorporating these visual real-time aids into treatment. A second point that we talk about here is this idea of communication, specifically of expectations. And this goes for our patients, but also for the therapist as well. So we refer to the folks we help as patients because originally we were a hospital, so I apologize if that's offensive. I know some people prefer the term clients. So we have to take care on one hand that the client understands that any differences in your expectations of them may be due to this change in therapy modality. So in other words, it may be that you're used to being able to lay eyes on your client who's in the same room and right there, and you can pick up a lot of information on this nonverbal or physical cues to figure out where they are. And it helps us find what might be called the sweet spot in terms of kind of finding that right place where arousal is occurring, but not an uncontrollable level of arousal. when the literal window that you're observing your client through is the screen of your phone or the screen of your laptop, even when we kind of zoom out to be able to see their whole body, it's very difficult to pick up that visual information that's very subtle to begin with. So the amount of information being conveyed shrinks quite a bit. You need to let your client know that you may be asking more questions or different questions than they might be used to, and why. That it doesn't have anything to do with something that's wrong with them or something that's changed about treatment. It has everything to do with kind of your level of concern and wanting to convey that information. By the same token, your client may have some different levels of comfort when we talk about them being on their turf at home or in their car or at the park or wherever they may be. Their level of comfort and seeing your role and kind of the relationship between you may be quite different than when they're on your turf, where kind of you set this level of structure and control, for lack of a better term, of what's about to happen. So it's very important for you to kind of assess that and kind of poke at that and see what comes out so that you're both metaphorically on the same page when it comes to this. And then that last part there where we talk about processing, again, the disconfirmatory information, there's so much importance here that's laid on communication and on checking for comprehension by your client, and also kind of their level of agreement with what you're finding. This is critical. It's really difficult to pick up on how they feel about what you're saying and kind of to pick up on all the information they're trying to convey to you while they're processing through this. So that may involve, because you have to explicitly talk or ask, that may involve a lot more direct questioning or even talking on your part than you may be used to. So it's really important to kind of be able to talk to them about why that's happening. It's also really important that we revisit psychoeducation and the rationale for prolonged exposure and imaginal exposure. This has to take into account some changes that are related to our current environment. Otherwise, if we shy away and we exceed the CDC recommendations, in terms of kind of telling them to be safe or to kind of do something more than what's necessary by CDC, what we're inadvertently doing is reinforcing these safety behaviors, which again was the whole purpose of in vivo exposures, was to decrease those safety behaviors. By the same token, if we're very aggressive and we ignore or overstep the CDC recommendations and kind of blow them off, we are actually increasing the legitimate risk to our clients, for one. And two, we run the risk that you're going to pick up quite a bit of resistance from your client, what you may perceive as them being resistant to treatment, when in fact this resistance really comes from appropriately assertive decision-making and problem solving on their part. And so we really have to kind of talk about how do we renegotiate this relationship and the nature of communication between us. If we could go to the next slide. Thank you. So some areas of concern, some things to watch for. What I really want you to remember about this, and we've talked a little bit about this, is that these imaginal exposures can, and in fact should be, informing what you do for in vivo exposures. So you may start out with what you feel and what your client is telling you are the triggers, a list of triggers to watch for, a list of things they avoid. It may become quite apparent, at least to you, through the course of these imaginal exposures, that there are far more triggers, or that the triggers they're talking about are one cluster and there are some that are more significant or some that are quite subtle that they're not recognizing. So we want to make sure that we're still continuing to allow these imaginal exposures to inform our in vivo exposure hierarchy. And then again, a lot of this communication we talk about really comes back to this point that it's really important that we collaborate with our clients on treatment planning and on goal setting. And I have no doubt that you're probably fantastic at this, so please don't take this as me chiding you for it. But what I'll point out is the amount of communication that we're used to, it has to increase to fill that gap we're talking about. So again, where this should show up more than almost anywhere else is in that amount of collaboration. We find that telehealth acts to make the link between us and our clients more tenuous. So anything we can do to kind of widen the span and increase the bridging effect is important to us. And the second thing I'll point out here is this notion of social distancing, safety behaviors. There's this counterintuitive piece. So again, and not only are these things due to pandemic where it's like, safety distancing, like what we've talked about, but also things that are around us every day that suddenly become more salient. So what I've put in quotations here is quite a common sales pitch for people who want to sell you things online, which is, why go to the store when you can buy online? Well, it turns out there's actually a pretty good reason why you should go to the store even when you can buy online. And it's because many times the clients we're working with avoid going to the store anyway, or avoid being around other people anyway. And now this has kind of given them a legitimate excuse and yet an excuse nonetheless. So it's very important that we kind of be aware of the impact of these statements, of the advertising that they may be exposed to, of the messaging that's coming out, the impact that that can have upon the safety behaviors that our patients may already be displaying, and that we kind of sort of tactically and strategically approach in vivo exposures accordingly. If you could go to the next slide, Dr. Post. Oh, never mind. You actually already did. Thank you very much. So when we talk about treatment via telehealth, there's obviously some advantages and challenges, and I've kind of listed them out. I want to flesh them out just a bit. So the first is this environmental authenticity. Normally, again, you would have your patient perhaps coming into your room, to your office, and what you see is what you get, quite literally. Here, even though it's a window that you have to look through that can provide a barrier, it's a really interesting window. In terms of you're getting to see in real time what these routines, sometimes what relational dynamics look like in the wild for your clients. And so that's a huge advantage of telehealth. It also allows us to bypass these common obstacles we've talked about. So again, when we come back to the reasons for attrition, transportation, blocking off the time, childcare, all those things, they either don't apply or they apply quite differently when we're talking about telehealth. Something where I've put potentially higher dosage, and again, the idea of dosage here meaning that the more time you're able to spend on the active ingredient of treatment, the more effective it will be. So, when we talk about this, you now have the opportunity to really kind of open the throttle, so to speak, on the exposure frequency, but also on the variety of exposures, because the client, instead of being in your office or being limited to what they may see on a day outside, you have quite a variety of things at your disposal in terms of being able to construct these exposures. So it gives us an opportunity we normally don't have here. The other thing I'll point out is this kind of increase in societal arousal. So to this point, we've really talked about how difficult it is to build motivation for people to do things they perceive as dangerous because everyone else sees them as dangerous too. If we reframe this and do a little bit of kind of cognitive judo here, what we can find is that traditionally it's really tough sometimes to find what might be called confederates when we're doing authentic exposure. So someone to be direct or maybe a little bit unreasonable or something like that with our clients. However, I guess to put it in a strange way, the beauty in having a lot of people on edge all the time is that your client probably is not going to engage in a lot of self-reassurance, which can be a safety behavior, or avoidance, or kind of seeking reassurance from people by telling themselves that it won't be that bad. If you haven't seen the news lately, there's plenty of people that will tell you that it is in fact that bad and worse. So there's kind of some things that are advantages that we don't always think of as advantages. If we flip this around and look at the challenges, we've talked a little bit about this in terms of the role shift. Much of our effort in imaginal exposures are usually geared towards building a sense of trust and rapport, so that people will feel comfortable with us visiting these particular sensations vicariously from our office. In telehealth, I'll point out really the only thing vicarious here is your observation, because these exposures, even though they're imaginal, are likely to be much more authentic for them because they are not in your office. They are in the place where they live day to day. So the challenges here are many, but a really big one includes how do you best provide therapeutic support as more of a witness rather than experiencing a sense of control by being able to help them shut that window from your office that you're used to. A second challenge here are what we might call safety behaviors by proxy. So for a lot of our patients, there's a sense of safety that's to be found not only in these safety behaviors that we talk about, but also again in the entire construct of their home and the environment around them, certain items, certain routines, certain areas of their home, certain arrangements they've made, travel patterns. We're not really used to, most of us, we're not really used to kind of helping folks within their house kind of identifying and externalizing and dismantling these types of quasi-safety behaviors in the wild. And again, this happens as well with in vivo exposures because, again, our entire societal structure surrounding kind of the most mundane of activities has pretty significantly shifted. We have covered technology issues ad nauseum. I don't know that I want to make you any more tired of hearing about that by telling you more about it. And then reimbursement is a big one. And I'm going to kind of hold on to that one because we're going to talk a little bit more about it as one of our stressors. So if we could move on to the next slide, Dr. Post. Thank you. So again, as I mentioned, some stressors. So there's this idea of what might be called the new normal, which is a pretty accurate term, but it's one I think some of us are tired of hearing, along with unprecedented times. So when we talk about the new normal and some of these considerations for transition, it's really important to take a look at what prompts us to do things. So specifically, when we look at moving from in-person to almost wholly or fully telehealth, these stressors, when we talk about moving to entirely virtual, these were prompted. And some of them were really legitimate in terms of some concerns about whether or not if I leave the house, am I going to get sick? Am I going to die? Am I going to infect other people? And so there's the kind of these stressors that show their head, and they're not really different than ones that we may be used to seeing from our patients or clients. But here now there are actually some legitimate concern behind it. But I'll also point out that some of the policies that have happened have really prompted this move. And specifically what I'm talking about are orders from your governor or, from the federal level, whatever it may be, to stay at home, or what might be called safer at home orders, the quarantine, not allowing non-essential businesses to be open. What's been nice about this is that there's been a loosening in most states of those telehealth and interstate telehealth treatment provisions, specifically for reimbursement and being able to be paid for your work. I know that we didn't get into this for the money, but we also didn't get into the business of helping people so that we could live under an overpass, right? So reimbursement turns out to be important. When we look at the shift back, there's really some different stressors that come into play. It isn't that our concerns about getting sick have gone away. It isn't that it's important to be reimbursed has stopped being a concern. But what we find is that our concerns, by and large, tend to be a lot more financial or social in nature. So again, kind of this idea of reimbursement, but also from your patient's or your client's standpoint, financially, most of us can't afford to simply stay home and not work. Many of our employers can't afford for us to stay home and not work and continue to pay us and provide us with health insurance as well. So it's a very different stressor that kind of pushes back and acts to try to equalize where we're going and push us back towards in-person. And then again, with the policies here, it's not been so much the lifting of the closures and things like that, but what we find is that the ability to access care, specifically through the expiration of interstate telehealth agreements, the expiration of within your own state telehealth agreements, that has put much more of pressure on the providers to be able to get people into their office so that they can be reimbursed, and also so that their clients can actually afford through their health insurance to be seen. So it's really important that we kind of keep in mind here that we have been pushed or prompted in both directions, but the nature of the push and prompt has been different on each one. So, and one of the challenges for us at Rogers, which may be different than you in the private experience or wherever you may be working, is we're an organization that operates clinics in states throughout the country. And so kind of not only do the states in which our regional clinics and our home clinic in Wisconsin operate have different telehealth requirements and allowances, but also the nature of the different states from which our patients originate differ in their willingness and allowance for their patients to be reimbursed. And sometimes we come up with some pretty odd combinations where a person in one state may not be able to get reimbursed or covered for services in one clinic, but they can in a clinic from a different state. So we actually have a task force of people who have to be tired, I imagine by this point, who do nothing but track the changes in those orders and the changes in the rules and regulations so that we continue to maximize access to care for our patients. So just a few things to think about. And I think what I've successfully managed to do is kind of end this right about where we were looking for at about the 75-minute mark. And I would love at this point to allow Michelle to kind of open this up for questions.
Thank you, Dr. Nadeau. The first question is, are you familiar with what are your thoughts about forward-facing trauma treatment and memory reconsolidation therapies?
I'm going to be very honest, and I'm going to say the three hardest words to say in the English language. I don't know. I am not familiar. That's kind of not really my area of expertise, so I'm really reluctant to speak upon it. It's possible that Dr. Post might know more about that or be willing to talk a little bit more about it.
I don't know that I can be very helpful either, but could you repeat the two terms used?
Yes. The question dropped off of the screen, so I am going to go to the next one. After we started, I dismissed, so I apologize. We could maybe come around later with an email on that one.
Okay.
How about, are there any clients presenting feeling further traumatized by the pandemic with a sense of further loss of control?
And Dr. Post may have more to say about this, but I'll jump in there first since I'm kind of already unmuted and nodding at the screen. Yes, we have seen some folks who present. I mean, we still have folks who present obviously with trauma, but there has been kind of a distinct uptick in the patients who are coming to us seeking treatment for PTSD, where they've seen an increase in their symptoms. And sometimes what actually may drive them to seek treatment now has been because this has been a very triggering aspect of their lives, in terms it's either revisiting a previous trigger. Again, we talked a little bit about things like being told to wear a mask and it restricting their breathing, or having their movements curtailed, or not being able to work and kind of having this feeling that I should be more productive than I am and I'm not. And so we get a lot of folks who are pretty good about beating up on themselves as a nature of the condition, and we find that show up a lot of times in treatment. Dr. Post, did you have more to say about that?
We are still hoping to get more of our PTSD patients, so I can't speak to that specifically, but certainly can hear that would be an expected presentation with everything that our patients are experiencing.
Thank you. The next question is, how do you suggest helping clients that prefer to continue with telehealth after the pandemic calms, especially clients that prefer to isolate?
That's a really good question, especially that last part about patients who prefer to isolate. So what I will say is this: as you see us making the shift from virtual to someday back to fully in person again, I think the idea of fully in person may end up being a misnomer. I'm not going to engage in fortune telling and tell you what it'll look like at Rogers, because I don't know, but I do suspect that there will be some reluctance. And ironically, I think a lot of folks had some reluctance of moving from in-person to telehealth and some discomfort. And some of those same folks may be now reluctant to come back to in-person. I'm not a big fan of putting people's arms up behind their back and kind of prison walking them back into the office. So what I would point out is that treatment of any sort is really better than treatment of no sort, as long as you're talking about like an evidence-based treatment approach. So what I would say is, if they are truly reluctant and resistant to coming back in clinic, I would still say that your telehealth treatment approach, as we've shown in this presentation, can be quite effective. We just want to be careful that we're not feeding into the safety behavior by allowing them to isolate. It's a good question.
The next question is, can a technique such as EMDR be done virtually?
That's another really good question. And again, Dr. Post may want to weigh in on this as well. My 2 cents to this would be as follows. So there is evidence to support EMDR. I think what you will find is some elements or some facets of EMDR, specifically this kind of the exposure piece of EMDR, which is very much there, would be relatively easy to emulate in a telehealth fashion. That's kind of what we've been talking about, as the exposure piece. As far as kind of the tracking and the use of eye movement, it's not really my specialty, so I can't speak to how well that works or if there have even been studies done on it. Dr. Post, do you know anything about that?
In terms of non-inferiority studies of EMDR and in-person treatment, they have not been conducted. So we don't really have the data on whether or not it can be as effective as we would hope it and want it to be.
Okay, thank you. The next question is, how can therapists differentiate between sincere fear of contracting COVID-19 and trauma-related avoidance and in vivo exposures?
Wow, it's a really good question. And I think that that has obviously much less to do with telehealth and kind of much more to do with kind of the nature and legitimacy of fears. One thing I'll point out, and I know that the person asking the question is aware of this, but I kind of want to say this so I don't come across the wrong way. I would hesitate to say that there is a realness to these legitimate concerns of kind of related to COVID-19 and quarantine, and saying at the same time that somehow fears related to trauma are illegitimate. I would point out that the feelings are exactly the same. So in terms of kind of, as we talk about processing, a very large part of what we do in terms of processing, not only through imaginal exposures, but in vivo exposures, has been kind of what is the utility of these safety behaviors? Is this truly keeping us safe? And is it going overboard? So again, we come back to this idea of following the CDC and kind of not the PTSD. When it's difficult to differentiate PTSD related fears or safety behaviors versus COVID-19 or CDC related fears, I think I would kind of point out that so long, when we talk about exposure-based therapies, so long as you are moving in the correct direction, so as long as you are moving towards what it is that's making you anxious, I'm far less concerned with how large a step you're taking. So in other words, what I'm saying is, regardless of whether it appears to be a safety behavior or a legitimate COVID-19 behavior, as long as you're not overstepping the CDC recommendations, I would say gradually break that down and still approach it in the same fashion. To some extent, my belief is that it doesn't really matter which one of those two it is, so long as we're normalizing what the behavioral expectations are in terms of keeping yourself safe. Dr. Post might have more to add to that.
Beautifully said.
Oh, thank you. That's very nice.
Thank you. The next question is, should I put temporarily inaccessible activities on my patients' in vivo exposure hierarchy, like going to a crowded mall, or would it be best to leave them off entirely?
That's a really question. So what I'll say is, please don't have your patient go to a crowded mall right now. And so kind of when we talk about this, again, those CDC recommendations, there is a lot being said about the idea of safe distancing and social distancing. What I'll point out is that even though we call these in vivo exposures, as we look at kind of gradually approaching them in a hierarchical fashion, you still can use analogs for that. There's nothing that says that they cannot watch a video on, I hesitate to say YouTube, but wherever your preferred internet video hosting service, of crowded situations. Of a tour through a mall at the middle of a lunch break or something like that. I mean, there are plenty of resources available. And when you're dealing with someone where that is a trigger for them, even though they're not there in reality, we find that we can still get that same kind of activation of the fear structure that we talked about before. So I'm not saying avoid the mall. Well, I am saying that right now. Don't go in the middle of lunch hour to the mall. But what I am saying is that don't let the fact that it is inaccessible in person stop you from utilizing that as a form of an in vivo exposure.
Thank you.
You guys are asking the tough questions today, man. All right.
Here's another for you. It seems that some clients find it easier to suppress or dull their emotions when completing imaginal exposure via telehealth versus in person. What suggestions do you have for greater emotional engagement if you're noticing this?
Oh, such a good question, man. Yeah, so we do see that, and not just in PTSD, I'll point out either. And so there's kind of this idea that, I'm really anxious right now, or I don't want to talk about it, or no, it's fine, we can move on. I think it's really important that, again, we come back to this idea of prolonged. And here what we're really looking for is kind of hanging out in that emotional state and recognizing that it will pass. And if what we find is that someone says, oh, it's fine, or they're kind of suppressing or trying to numb their emotions so that you'll move on, it's really important that we kind of sit there so that at the end of this, we are able to process through and show disconfirmatory information. Having said that, if you step through this exposure and they're still unwilling to, or maybe unable to at that point in time, kind of authentically express their emotion, there's still something to be learned here. Okay, and so what I would say is, as you step back through the processing of this, that's a very real part of it. Is what was that like for you? What is it like? Because the impression I have is that perhaps you were feeling much stronger emotion than you let yourself feel. What's it like to know that? How was this experience for you in that moment when you wanted nothing more than to just move on, and yet I insisted that we stay and smell the emotional flowers, so to speak. And so, I think that there are very few times when you will see a bad exposure, or an exposure that there isn't something constructive that comes out of it. It's a really good question.
Thank you. The next question is, I'm concerned a digital recorder or patient cell phone won't pick up the therapist's audio during imaginal exposure or during post-exposure processing. Has this worked in your experience, and have you provided specific instructions on where the patient should place the recording device?
Dr. Post may have more to add here, and I feel like a broken record when I say that. I haven't run into that yet with digital recording. Something that's been interesting that I've seen, and we have not done this through Rogers, but in talking with colleagues who have been doing outpatient practice, when you're using a HIPAA compliant device, so when we talk about, like for our organization, we use a secured version of Teams, that allows you the option of being able to actually record the session in real time. And although it is video so that you can watch it, if you haven't really ever thought about it before, the only difference between it being video and audio is that you're watching it or you're not. So if you have that accessible to you and can play it back as a streamed video to your phone or your broadcasting device of choice, you can plug headphones into it and still use it the same way. There's nothing that says that you have to watch it as a video. So it's certainly an option. There may be other options Dr. Post is aware of. It's something relatively new to me.
Yeah, I think that is a great alternative to consider. I don't have many other creative solutions outside of that. I think that it can still be effective to use digital recorders or even old school like tape recorders, as long as it's positioned in a place where the voice of the patient is clear, and if possible, the provider as well, so that when the patient is listening to the recording for homework, they can make sure that they're kind of fully engaged with the process that they had gone through during session of revisiting that memory.
Thank you. The next question is, do you have any suggestions for in vivo exposures for hypervigilant, crowd-avoidant patients that remain safe and appropriate during COVID-19 pandemic?
So I think there's a lot of cool creative things that we could do, particularly for hypervigilance. Many of them we may already be suggesting to our patients. So things like if we want our patients to stay at home in order to kind of maintain social distancing, avoiding crowds, sometimes a matter of keeping headphones in if there is concern about not being able to hear what's going around or going on around a person, keeping headphones in while sitting in the home, sometimes even closing eyes with headphones in. We could ask people to go outside and keep their back to the street so they're not able to really see if anybody's walking by or cars are driving by. I think those are just a couple, but I think that we can certainly still evoke that fear of not knowing and not being able to have all of this information within our situation, and asking them to do that at home and via telehealth.
Okay. Thank you again, Drs. Nadeau and Post, for taking time away from your clinical practice, as well as sharing your valuable insights with us. I'd also like to let you all know that Rogers is here for those who are struggling with mental health or addiction, now potentially more than ever. We are continuing to accept patients in both our inpatient and residential settings in Wisconsin. And we are very proud to offer Rogers Connect Care, our virtual option for those needing intensive outpatient levels of care. And based on recent decisions made in several states, we will begin transitioning some of our partial and intensive outpatient care services back to our clinics using a hybrid model of on-site and virtual treatment. While these patients will be physically in the clinic, they will continue to use the same virtual treatment via Microsoft Teams while on site. Drs. Nadeau and Post, before we conclude, could you please share your recommendations on additional resources for our participants?
Sure, I guess I'll go first. I mean, for me, and you can see some of these up here in terms of the VA is a fantastic resource for information. And again, kind of keep in mind that the majority of the research that's been done has been on veterans, but they really have interestingly led the way in terms of kind of novel approaches and in terms of really interesting cases and things that make treatment more or less difficult. So, I mean, I'm actually a veteran and was in the government for 12 years. So you have no idea how absurd it is for me to think about the fact that the VA is leading the way in this. I mean, it's still a little bit of a joke there, but they are an absolute fantastic resource in terms of evidence for that.
Yes, and definitely some of the sites related to coronavirus specifically, the CDC, NIH, and then in more management of anxiety, including PTSD and other anxiety disorders, can be found at Anxiety and Depression Association of America, so ADA website.
Thank you. That about wraps it up, everyone. I want to remind our participants that those of you who met the required time commitment will be eligible for CE credits. About 30 minutes after the webinar ends, you will receive an email with a link to the mandatory evaluation form. Once you complete it, you may download your CE certificate for the event. We will have a recording of today's webinar, and the slides will be available on our website, rogersbh.org. If you were unable to join the first webinar series on the treatment of trauma during COVID-19, please visit the resources section of our website to watch it at your convenience. Next week, Thursday, May 28th, we will offer the first of a two-part webinar series on treating eating disorders with the medical and clinical directors of Rogers Eating Disorder Recovery Services. Keep an eye on your inbox for details. On behalf of everyone at Rogers, we look forward to partnering with you to help support your patients. Thank you.